Hello everyone, in today's session we have Dr. S. Raghavendra, Consultant Neurologist and Epileptologist at Vikram Hospitals, Bangalore, a unit of Manipal Hospitals. So in today's discussion, it is about epilepsy and seizures. So let's start with some basic questions. So doctor, what is epilepsy?
ಎಪಿಲೆಪ್ಸಿ ಅಥವಾ ಮೂರ್ಛೆ ರೋಗ ಅಂತ ನಾವೇನು ಹೇಳ್ತೀವಿ, ಇದೊಂದು ಮೆಡಿಕಲ್ ಕಂಡೀಷನ್. ಇದರಲ್ಲಿ ಇಟ್ಸ್ ಎ ವೆರಿ ಕಾಮನ್ಲಿ ಅಕರಿಂಗ್ ಮೆಡಿಕಲ್ ಕಂಡೀಷನ್. ಇದರಲ್ಲಿ ನಮ್ಮ ಬ್ರೈನ್ ಸೆಲ್ಸ್ ಅಥವಾ ನ್ಯೂರಾನ್ಸ್ ಅಂತ ಏನು ಹೇಳ್ತೀವಿ, ಇಟ್ ಲೀಡ್ಸ್ ಟು ಸಮ್ ಅನ್ಎಕ್ಸ್ಪೆಕ್ಟೆಡ್ಲಿ ಅಬ್ನಾರ್ಮಲ್ ಡಿಸ್ಚಾರ್ಜಸ್ ವಿಚ್ ಇಸ್ ನಾಟ್ ಪ್ಲ್ಯಾನ್ಡ್. ಸೊ ಬಿಕಾಸ್ ಇಟ್ ಈಸ್ ನಾಟ್ ಪ್ಲ್ಯಾನ್ಡ್, that area of brain does some functions unexpectedly in some situations which is not warranted, which leads to abnormal activities and behavior of that person. ಇದಕ್ಕೆ ನಾವು ಎಪಿಲೆಪ್ಸಿ ಅಂತ ಹೇಳ್ತೀವಿ. ಇನ್ ಎ ಕಾಮನ್ ಟರ್ಮ್, ವಾಟ್ ನಮ್ಮ ಜನಗಳು ಏನು ಅರ್ಥ ಮಾಡ್ಕೋತೀವಿ ಅಂದರೆ, ನಾವು ನಾರ್ಮಲ್ ಆಗಿದ್ದಾಗ ಸಡನ್ನಾಗಿ ಅಬ್ನಾರ್ಮಲ್ ಎಲೆಕ್ಟ್ರಿಕಲ್ ಡಿಸ್ಚಾರ್ಜಸ್ ಬಂದರೆ ನಾವು ಮಾಡೋ ಕೆಲಸ ನಿಲ್ಲಿಸ್ಬೋದು, ಕಣ್ ಬ್ಲಿಂಕ್ ಮಾಡ್ಬೋದು, ಇಲ್ಲ ಬಿದ್ದು ಕೈ ಕಾಲೆಲ್ಲ ಒದ್ರ ಹಾಗೆ ಮಾಡ್ಬೋದು, ವಿಚ್ ಈಸ್ ಕಾಮನ್ಲಿ ಥಾಟ್ ಆಸ್ ಎಪಿಲೆಪ್ಸಿ ಅಲೋನ್ ಇನ್ ಕಾಮನ್ ಲೇಮ್ಯಾನ್ ಟರ್ಮ್ಸ್. ಈ ಥರ ಎಲ್ಲ ತುಂಬ ಸಿಂಪ್ಟಮ್ಸ್ ಬರುತ್ತೆ. ಇದಕ್ಕೆ ನಾವು ಎಪಿಲೆಪ್ಸಿ ಅಂತ ಹೇಳ್ತೀವಿ. ಒಂದು ಇಂಪಾರ್ಟೆಂಟ್ ಥಿಂಗ್ ಅಂದರೆ, ಒಂದು ಮನುಷ್ಯನಿಗೆ ಎಪಿಲೆಪ್ಸಿ ಅಂತ ಬಂದರೆ ಜನರಲ್ ಆಗಿ ಅದೇ ಲಕ್ಷಣಗಳು ಪದೇ ಪದೇ ಬರ್ತಾ ಇರುತ್ತೆ, which helps us make the right diagnosis. This is epilepsy and not something else which can be confused as epilepsy.
So when does a person have a seizure attack? Are there any trigger points?
There is a small medical difference in when we call seizure or epilepsy. Seizure means generally in a term we call it as a single attack. A single seizure, somebody tells I had a seizure, it need not necessarily mean they have epilepsy. ಎಪಿಲೆಪ್ಸಿ ನಾನು ಹೇಳಿದಾಗೆ ಒಂದೇನು ಅಂದರೆ, ಪದೇ ಪದೇ ಅದೇ ಥರ ಲಕ್ಷಣಗಳು ಬರಬೇಕು. ಅಂದರೆ ಸಂಬಡಿ ಶುಡ್ ಹ್ಯಾವ್ ರಿಕರೆಂಟ್ ಎಪಿಸೋಡ್ಸ್ ಆಫ್ ದಿಸ್ abnormal neuronal discharges. So generally it gives you the same symptoms in that patient. And most important, it should not be triggered. So when a person has repeated episodes of neurological symptoms, it is called epilepsy. And if it is one attack, it is called a seizure generally. A seizure does not mean epilepsy. Multiple seizures means epilepsy. There are various triggers. ನಾವು ಹುಟ್ಟಿದ ಮನುಷ್ಯನಿಗೆ ಸಾಯೋದ್ರೊಳಗೆ ಒಂದು 5% ರಿಸ್ಕ್ ಇರ್ತದೆ ಒನ್ ಎಪಿಸೋಡ್ ಆಫ್ ಸೀಜರ್ ಆಗಿ. ಇಟ್ ಮೇ ಬಿ ಲ್ಯಾಕ್ ಆಫ್ ಸ್ಲೀಪ್, ಇಟ್ ಮೇ ಬಿ ಎಮೋಷನಲ್ ಸ್ಟ್ರೆಸ್, ಇಟ್ ಮೇ ಬಿ ಸಮಟೈಮ್ಸ್ ಸಮ್ ಆಂಟಿಬಯೋಟಿಕ್ಸ್, ಹೆಡ್ ಇಂಜುರೀಸ್, ಆ್ಯಂಡ್ ಆಲ್ಕೋಹಾಲ್ ಬಿಂಜ್. ಸೊ ವೇರಿಯಸ್ ಟ್ರಿಗರ್ಸ್ ವಿಚ್ ಮೇಕ್ಸ್ ಯುವರ್ ಬ್ರೈನ್ ಅನ್ಸ್ಟೇಬಲ್.
Could you also highlight about what are the symptoms? ಈಗ ಒಬ್ಬರಿಗೆ ಎಪಿಲೆಪ್ಸಿ ಅಥವಾ ಸೀಜರ್ಸ್ ಆಗ್ತಿದೆ ಅಂತ ಹೇಗೆ ಗೊತ್ತಾಗುತ್ತೆ?
ಎಪಿಲೆಪ್ಸಿ ನಾವು ಕಾಮನ್ ಮನುಷ್ಯ ಅಂದ್ಕೊಂಡಂಗೆ ಯೂಶಲಿ ನಮ್ಮ ಜನರಲ್ ಅನಿಸಿಕೆ ಏನು ಅಂದರೆ, ನಡೀತಾ ಇರ್ತಾರೆ, ಬಿದ್ದುಬಿಡ್ತಾರೆ, ಕೈ ಕಾಲೆಲ್ಲ ಒದರುತ್ತಾರೆ, ನಾಲ್ಗೆ ಕಚ್ಕೋತಾರೆ, ರಕ್ತ ಬರ್ತದೆ, ನೊರೆ ಬರುತ್ತೆ, ಇದು ಅಂದರೆ ಎಪಿಲೆಪ್ಸಿ ಸೈನ್ ಈಕ್ವಲ್. ಬಟ್ ಮೋಸ್ಟ್ ಆಫನ್ ದಿಸ್ ಇಸ್ ನಾಟ್ ದ ಕೇಸ್. ಸೊ ನಾನು ಹೇಳಿದಾಗೆ ಬ್ರೈನ್ಗೆ ಸಿಕ್ಕಾಪಟ್ಟೆ ಫಂಕ್ಷನ್ಸ್ ಉಂಟು, ಎಲ್ಲ ಥರ ಕೆಲಸ ಮಾಡ್ತಾರೆ. ಸೊ ಒಂದು ಅಬ್ನಾರ್ಮಲ್ ನ್ಯೂರಾಲಜಿಕಲ್ ಎಲೆಕ್ಟ್ರಿಕಲ್ ಡಿಸ್ಚಾರ್ಜ್ ಬಂದಾಗ ಆ ಬ್ರೈನಲ್ಲಿ ಏನೇನು ಫಂಕ್ಷನ್ಸ್ ಮಾಡೋ ಕೆಪಾಸಿಟಿ ಇರುತ್ತೆ ಎಲ್ಲ ಬರ್ತದೆ. ಬ್ರೈನಲ್ಲಿ ಎಲ್ಲ ಆರ್ಗನೈಸ್ಡ್ ಇರ್ತದೆ ಫಂಕ್ಷನ್ಸ್. ಇಟ್ಸ್ ಲೈಕ್ ಎ ಕಂಪ್ಯೂಟರ್. ಯು ಹ್ಯಾವ್ ಫ್ರಂಟಲ್ ಲೋಬ್, ಯು ಹ್ಯಾವ್ ಮೋಟರ್ ಸ್ಟೇಪ್ಸ್, ಯು ಹ್ಯಾವ್ ಸೆನ್ಸರಿ ಏರಿಯಾಸ್, ಯು ಹ್ಯಾವ್ ವಿಷುವಲ್ ಏರಿಯಾಸ್, ಯು ಹ್ಯಾವ್ ಮೆಮೊರಿ ಏರಿಯಾಸ್. ಎಲ್ಲಿಂದ ಶುರು ಆಗ್ತದೋ ನಮಗೆ ಆ ಥರ ಸಿಂಪ್ಟಮ್ಸ್ ಬರ್ತದೆ ಫಸ್ಟ್. ಅದಕ್ಕೆ ನಾವು ಯೂಶಲಿ ಆರಾ ಅಂತ ಹೇಳ್ತೀವಿ. Suppose it starts from my memory area. I might get some old memory. I may feel this has happened before. I may get some abnormal sensations. It may go on for 5-10 seconds. And when the electrical discharges spreads onto the other areas, I may lose connection with my environment. I may just remain still. I may do some oral movements, automatism, smacking a thing. I may do some hand movements. I may just get up and walk around and come back. Usually, these are the symptoms. Some people get attacks only in sleep. ಕೆಲವರಿಗೆ ಮಕ್ಕಳಿಗೆ ಚೈಲ್ಡ್ಹುಡ್ ಎಪಿಲೆಪ್ಸಿ ಎಲ್ಲ ಟಿಪಿಕಲ್ ನಿದ್ರೆಯಲ್ಲಿ ಅಮ್ಮಂಗೆ ಗೊತ್ತಾಗ್ತದೆ, ಮಗು ಅಲ್ಲಾಡಿದಾಗ ಎದ್ದು ನೋಡ್ತಾರೆ. ದೋಸ್ ಕ್ಯಾನ್ ಆಲ್ಸೋ ಬಿ ಸಿಂಪ್ಟಮ್ಸ್ ಆಫ್ ಎಪಿಲೆಪ್ಸಿ. ಸೊ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಈಸ್ ವೆನ್ ಯು ಫೈಂಡ್ ಎನಿಥಿಂಗ್ ಹ್ಯಾಪನಿಂಗ್ ಅಗೇನ್ ಆ್ಯಂಡ್ ಅಗೇನ್ ಇನ್ ಎ ಸೇಮ್ ಪ್ಯಾಟರ್ನ್ ಇನ್ ಎ ಗಿವನ್ ಪರ್ಸನ್, ಇಟ್ ಮೇ ಬಿ ಎ ರೆಡ್ ಫ್ಲಾಗ್ ದಟ್ ಹಿ ಈಸ್ ಹ್ಯಾವಿಂಗ್ ಎಪಿಲೆಪ್ಸಿ.
So if somebody comes to hospital with an epilepsy attack, a possible epilepsy attack, how do we diagnose?
A very interesting question, because many people think they go to the hospital, they tell some symptoms, and the doctor will do some tests and they say whether this person is having epilepsy or not. That's not the case. epilepsy is a pure clinical diagnosis. That means somebody should have seen, and usually you need a witness, somebody who has seen comes and tells them ಈ ಮನುಷ್ಯನಿಗೆ ಈ ಥರ ಲಕ್ಷಣಗಳು ಪದೇ ಪದೇ ಆಗುತ್ತೆ. ಅವರಮ್ಮ ಹೇಳ್ದಂಗೆ this might be eye blinking, this may be an eye movement, it may be a fall. So predominantly it is a clinical diagnosis. That means history is the one which tells you what the diagnosis is. There are no investigational tools which can confirm that patient has had a diagnosis. But some of them helps. For example, when a patient comes to you with epilepsy, with suspicion of epilepsy, history is suggestive of epilepsy, we do an EEG and say the EEG shows continuous abnormal. So EEG ಮಾಡಿದಾಗ ನಮ್ಗೆ ಹೇಗೆ ECG ಮಾಡಿ ಹಾರ್ಟ್ ಎಲೆಕ್ಟ್ರಿಕಲ್ ಆಕ್ಟಿವಿಟಿ ನೋಡ್ತೀವೋ ಹಾಗೆ ಬ್ರೈನ್ ಮೇಲೆ ವೈರ್ಸ್ ಇಟ್ಟು EEG ಮಾಡ್ತೀವಿ. ಸೊ ಬೇಸಿಕಲಿ ದಿಸ್ ಶೋಸ್ ಯು ಎಲೆಕ್ಟ್ರಿಕಲ್ ಆಕ್ಟಿವಿಟಿ ಆಫ್ ದಿ ಬ್ರೈನ್. ಸೊ ಆ ಥರ ಸಿಚುಯೇಷನಲ್ಲಿ ನಮಗೆ ಇಫ್ ಸಂಬಡೀಸ್ EEG ಇಸ್ ಅಬ್ನಾರ್ಮಲ್, ಕಂಟಿನ್ಯೂಸ್ ಆಗಿ ಒಂದು ಕಡೆ ಆಕ್ಟಿವಿಟೀಸ್ ಕಡಿಮೆ ಇದೆ, ಅಲ್ಲಿ ಎಪಿಲೆಪ್ಟಿಕ್ ಡಿಸ್ಚಾರ್ಜಸ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಸ್ಪಾರ್ಕ್ಸ್ ಬರ್ತಾ ಇದೆ, those are very strong corroborative evidence to what the history comes out. ಈ ಥರ ಸಿಚುಯೇಷನಲ್ಲಿ we may end up doing an further test like an MRI brain ಅಂತ ಹೇಳ್ತೀವಿ. ಒಂದು ಹಿಸ್ಟ್ರಿ, ವಾಟ್ ಯು ಹಿಯರ್, ಒಂದು ಎಲೆಕ್ಟ್ರಿಕಲ್ ಅಸೆಸ್ಮೆಂಟ್ ಆಫ್ ಬ್ರೈನ್, ಮೂರನೇದು ಸ್ಟ್ರಕ್ಚರಲ್ ಅಸೆಸ್ಮೆಂಟ್ ಆಫ್ ಬ್ರೈನ್. ನವಡೇಸ್ ಎವ್ರಿವೇರ್ ದರ್ ಇಸ್ ಎ ಗುಡ್ MRI 1.5 Tesla. MRI ಮಾಡಿದಾಗ ನಮಗೆ ಬ್ರೈನಲ್ಲಿ ಸ್ಟ್ರಕ್ಚರ್ ಹೇಗಿದೆ ಅಂತೆಲ್ಲ ಗೊತ್ತು. Suppose somebody has a scar with what the history matches. EEG may show, EEG may not show, EEG shows very good. MRI also shows. These become corroborative evidences for you to confirm and conclude with that available history that this patient has epilepsy.
So doctor, can you please throw some light on management of epilepsy in a clinical situation?
There are multiple medications available. They work very well. I would say the choice of medication in a given person depends nowadays on the profile of the patient. So there are lots of drugs which work very well. For example, somebody is planning pregnancy, you would use medicines which are safe in pregnancy. For somebody who is old, you would want to use medicines which are not doing too much of interactions with other drugs what he is taking. So, and also not affecting his cognitive performances, and choose drugs which are very good in that age group. If somebody is a child, you would choose medications which suits the exact clinical syndrome. Epilepsy ಅಂದಿದ ತಕ್ಷಣ ಎಲ್ಲ ಒಂದೇ ಅಲ್ಲ. ಎಪಿಲೆಪ್ಸಿಲಿ ಹಲವಾರು ಥರ ಇರುತ್ತೆ. ಕೆಲವು ಸೆಲ್ಫ್ ಲಿಮಿಟಿಂಗು, ಸ್ವಲ್ಪ ವರ್ಷಗಳು ಕಂಡು ಅವನು ಆ್ಯಸ್ ಇ ಗ್ರೋಸ್ ಇಟ್ ಗೋಸ್ ಅವೇ. ಸಮ್ ಟೆಂಡ್ ಟು ಬಿ ಲೈಫ್ ಲಾಂಗ್ ಸಿಚುಯೇಷನ್ಸ್. Depending on the type of the epilepsy, the profile of the patient, if somebody is obese, we may use medicines which actually may reduce medication. Weight, some medicines have adverse effect of putting on weight, some have adverse effect of reducing weight. Suppose, hypothetically, somebody comes to you, failed 5 drugs, and then you do an EEG which shows it's coming from one spot, and you do a very good MRI and there is a small scar, lesion or whatever, which can be safely removed. Those are the patients who may be considered for surgical things, provided they have an approach and aptitude for it. Then we have neuropsychological testing which is done to see how good they are from that part of the brain, whether they'll be able to take this sort of a decision making. And if everything fits, yes, there is definitely a significant portion of patients who can get better with this sort of more advanced care. Telling that, bottom line, most patients do well with right drug and right doses and proper lifestyle modification and being very, very careful about what they do.
So doctor, when do these patients require, when do they need a special care?
This, if you take in a country of 1.5 billion, this 1.5% is quite substantial. Even if it is 0.5%. These are the patients who need neurologists or physicians who have interest in managing epilepsy to see right combinations and work with them. These are the patients who need to take help from specialized centers which deal with these sort of drug resistant epilepsies who require, as I told you, more management. There are also various other tests which may need to be done on these patients, which may include a PET test, which is to check certain areas of brain is abnormal or not. We also do a test called functional MRI where we can find out which area of the brain has hand functions, language functions, memory by putting them in an MRI. So these are specific protocols where certain centers do this on a more frequent basis. The only other specific indication I would see is say a special situation like epilepsy with pregnancy, where you may need to be much more in a center which deals with them on a more frequent way, especially if they are little difficult epilepsies that they should not flare up, have risk for the mother baby.
Can women with epilepsy have a normal reproductive career, or do they have to be more careful?
There are few things which we need to be careful. By and large, men and women are equal in terms of epilepsy as with any other dynamics of life what we take. Only thing is, when we know a lady who is in the pregnancy age group, one thing is we need to talk to them early as to make the right choices. Certain medications, all medications can have minor adverse effects on pregnancy, maybe 2%. So if you are able to choose the right medication is the first step, because it may improve our fertility rates, we may be able to take care of it. There is a medicine called folic acid, which is a vitamin, which is known to prevent the known side effects of the medications on the baby. So we want to start it quite early, few months, 3 months before a planned pregnancy, so that you are negating the effects of these medications in the pregnancy.
Correct.
And once into pregnancy, in many places, some of the difficult patients require drug monitoring. What happens in pregnancy is there is a slight risk of seizures, and there is some risk for baby to have hit by the medications. So once you are very well controlled for a year before pregnancy, we know this patient is going to do very well. We just make sure she is on the same drug. We check the blood and make sure the drug levels are maintained during pregnancy. Pregnancy medicines levels keep dropping down, especially second trimester, third trimester.
Okay.
So we need to manage those drugs by 1 or 2 blood tests to make sure they are in good therapeutic range. And other important thing is the child requires little more monitoring. Pregnancy from 6 weeks one scan, 12 weeks one scan, 18 weeks on detail one scan. And other common problem is the myth that they should not breastfeed on when they are on medications. Time and again it is shown that when the breastfeeding is the best thing for the baby.
Yes.
So it is important to reinforce that yes, they need to continue breastfeeding, which is far more beneficial than any of the possible small portion of drugs which may go in the breast milk. So putting these things together, it's more a social problem, still understanding and getting into it rather than a medical issue where it can be well planned and well executed through and through.
Thank you so much, Doctor. If you have more queries, please write your questions on the comment section below.